Hello, everyone. Good evening, and welcome to yet another episode of ICPA Clinical Series. ICPA Clinical Series runs by the philosophy of each episode, one clinical challenge. We have completed 12 episodes, and in each episode, we have taken up one clinically relevant clinical challenge, and our expert speakers have solved those problems. And today, we are in for a treat, and we have Dr. Madhur Kankaria with us. Dr. Madhur is an oral maxillofacial surgeon who practices in Mumbai. He completed his MDS from D.R. Patil, Navi Mumbai with a gold medal in OMFS in 2016. After that, he completed a six-month fellowship program in advanced bone reconstructive surgery under Professor Istvan Arban in Budapest, Hungary. That was in 2017. And then he trained under Professor Thomas Linkevicius in Vilnius, Lithuania for zero bone loss concept. And this was in 2018. And next year, Dr. Madhur completed his soft tissue regeneration technique course on soft tissue regeneration techniques around implants and teeth with Professor Giovanni Zucchelli. So all those great mentors that we keep talking about, Dr. Madhur is trained under all of them, and we keep seeing his amazing cases, the way he documents his cases, the way he presents his cases. We have been seeing them all for last so many years, and today he is here to talk on a very relevant topic to all those people who are practicing implantology. Whether you are a beginner or a seasoned practitioner in implantology, this topic is very relevant for you, and Madhur will take us through his experience of uh, guided bone regeneration, one of the most vital concepts in implantology. And today, his topic is a surgeon's guide to avoiding mishaps with GBR. It's all over to you, Madhur.
Thank you so much, sir. Uh, I'd like to thank ICPA. I'd like to thank Rajiv sir for giving me the privilege of lecturing on such a amazing platform with a amazing reach of so many dentists. And it's really an honor for me to be here tonight. And I'd like to thank each and every one of y'all to for listening to me after a busy day of your practice. Cutting everything short, since we are a little short on time, I'll just get into it. My topic for today is to give you a brief idea of the mishaps or the complications that can arise with GBR, and how we can go about ensuring that that doesn't happen. So I'll be going into detail about each of them. And the way I'd like to go about it is just give a brief talk about what GBR is essentially all about, what principles one needs to follow to ensure that we have a good and a successful outcome. I'll talk briefly about the patient selection. Majority of the cases that I have seen are that have complications that have happened, or there are some mishaps, are originating from an inappropriate or an incomplete understanding of what type of defect that one is dealing with and what biomaterials one needs to use in order to treat that defect. So I'll be concentrating a majority of the talk on what type of defects that can present in your daily practice and how will you go about treating them. I'll then briefly talk about some surgical mishaps, something like a neurological or a vascular damage, how one should handle the flaps to ensure that you don't have any exposures, and eventually finish up with talking about some healing complications such as exposure and infection. So nothing summarizes GBR completely the way this article does by Wang and Boyapati back in 2006. It's called as the past principle. So essentially what this article states is that for you to have a successful GBR or a successful bone regenerative outcome, you need primary wound closure to ensure that the wound is completely undisturbed. There's no healing which is interrupted. You need a good amount of angiogenesis to provide all the necessary blood supply, all the undifferentiated mesenchymal cells. You need a good amount of space maintenance to ensure that you have adequate space for bone ingrowth, so that you can exclude all these other competing cells and resorptive stimuli that come into the picture the moment you do such a procedure. More importantly, you want the bone graft to be stable. This is a complete article for one to understand what GBR is all about, uh, which is basically a form of tissue engineering. So, what exactly is tissue engineering? Can easily be described by having something that has four actors. The first one is, of course, scaffold, growth factors, blood clot, and cells. But out of this, the most important one that I feel is the scaffold. Now, what exactly is the scaffold? So, scaffold is a three-dimensional a three-dimensional pattern or a three-dimensional object that is physically positioned in our patients. Now, this scaffold works as a three-dimensional area that incorporates all the growth factors that you have, that you can have inside the body, that have been specifically working with platelet derived growth factor. You can also see that the blood clot is also a big important player here. The growth factors basically have in general, have the function of attracting the host cells and differentiating them into the correct lineage. So we want them, in our case, to transform themselves and differentiates into osteoblast. Now, of course, last but not the least, you also have the cells, or potentially rebuilding the bone in three dimension in extreme cases to our patients without using autogenous bone. This is what essentially we were thinking previously. But it is actually a paradox. We would like to regrow bone without using bone, but that's not going to be possible. You need the right kind of cells to ensure that you have a good amount of bone regeneration. So we move on to the most important factor here, which is to select the right kind of patient. What would one do? Most often, if we see a patient with deficient bone, we try and go ahead with a bone regenerative process, where sometimes in the rush of our daily practice, or just to ensure that we get our we ensure that we want to do more of these cases, we just rush into these kind of cases. But the first thing that we need to do when a patient comes into our practice with a deficient bone site is to ensure that there is adequate compliance. He has a good hygiene. He's up to date as to what he's going to undergo, what the entire treatment is going to entail. We need to explain all of these things to him. So a classic case in point is this. This patient came to us with this kind of a dentition that you see in the upper left area, and obviously you can't proceed with a GBR in this kind of a case. You need to eliminate all the pathology. You need to ensure that he stops smoking. He was a chronic smoker. We'll get into the details about why one needs to stop smoking. So once we ensured that he knew about everything, what he was getting into, what this entire treatment would entail, we made him understand everything, ensured that the hygiene is up to the mark. Only then did we go ahead with extensive surgery like a GBR in the anterior mandible. So, of course, it also helps with these kind of patients to stage the process rather than doing everything in one go. My suggestion would be just do the extractions first, get all the pathology out, ensure that he has a good amount of compliance for us to do these kind of processes, and then proceed with whatever we need to do. Of course, smoking definitely has its own disadvantages. You need to ensure that the patient has to be non-smoking at least 6 weeks before we. I'm sorry.
Okay, I found this on the web for has to be non-smoking at least 6 weeks before we. I'm sorry. Check it.
Yeah, sorry, that was my Siri. So we need to ensure that the patient is not smoking at least 6 weeks before bone regeneration surgery, and 6 weeks post-op. Now, all of this is to ensure that there's a good amount of recovery of blood viscosity and platelet adhesion. We know that smoking does all these things. It causes peripheral vasoconstriction, decreased tissue perfusion, tissue ischemia, suppresses the function of neutrophils, which all eventually is going to lead to a failure of the bone graft. So one thing that I feel we should have a norm for all our implant patients, forget guided bone regeneration patients, is that we need to achieve a good amount of periodontal health before we start off. That includes a good scaling, thorough root planing before the process. Ensure that all the teeth are extracted either on the day of augmentation or at least 6 to 8 weeks prior to augmentation. Now, why is that? Because you want a good amount of epithelium covering your defect site, right? You don't want a deficiency there in terms of epithelialization, because eventually that's going to impact your coverage of the bone graft. If there's any soft tissue deficiency, that should be addressed preoperatively. Ideally, I would like any soft tissue deficiency to be addressed at least 6 weeks or 8 weeks before I plan to do the bone regenerative process. So we'll now move on to the osseous defects morphology. For the ease of understanding, I've divided into 5 defects. The first defect can be classified as a contour defect. Now, essentially, what does it mean? It means that you're still able to place the implant, albeit without the 2 millimeters facial bone around it, or if there's even less than 2 millimeters of facial bone around the implant, that is called as a contour defect. So what you would want to do for a case like this is that you can see on the screen that once the implant is placed, you have only a millimeter of bone or maybe a millimeter and a half here, right? So you want to ensure that you put some bone graft there to compensate for the negative architecture and eventually have a positive architecture here. So what we did was we used some anorganic bovine bone mineral such as BioOss, and we used a membrane such as BioGuide, which you can see on the picture on the right hand side, and created a positive soft tissue architecture. So a membrane here is not really necessary, but if you feel that the defect demands it, if you feel that the bone graft is not going to be stable, we go back again to the principles of bone regeneration. So the idea here is to whether it's a contour graft or it's a out and out guided bone regeneration where you're actually regenerating bone, the principle still stays the same. You need to stabilize the bone graft. You need to ensure that it's protected. The principle of a contour graft is, by definition, you're just increasing the contour, but that doesn't mean that you would want your bone graft to be flapping about and just being there very flimsily placed. So in this case, I found that I was not able to achieve that stability. That's the reason I went ahead and used a membrane, and eventually we had a tension-free closure. So here that you can see, we've now established a positive soft tissue architecture. We went ahead and loaded the case, and that's how you finish. So eventually you do have a good, reasonable outcome here. Now, what would you want to do if you have a case like this? What are the biomaterials that you would use? My suggestion would be that you use either an autogenous and or a demineralized bovine bone mineral such as BioOss. You do not need to use autogenous here. It's, I feel, overkill. But if you're, say, making an osteotomy, and if you happen to drill at a speed which is slower than 800 without irrigation, you can definitely gather some bone shavings that you drill through the osteotomy for. You can combine that with such as a BioOss or any other xenograft of your choice, and then you can layer it on top of the defect. Of course, the barrier here, like I said, is going to be optional. It's going to be depending on the kind of defect. If you feel that it's not stable, then you need to use it. Always remember that a contour defect will be covered by a resorbable membrane only. Non-resolvable membrane here is frankly overkill. It's not necessary. So that's one thing that you need to bear in mind. The next case that we move on to, or the next type of defect that we move on to, is an intraalveolar defect, which is essentially what you get when you're extracting the tooth. So a case in point is this patient here, where we extracted one of our canines. The osteotomy was palatal to the socket, and we ensured that the implant was in the right prosthetically driven position. Now, in this case, what I did was I harvested some autogenous shavings from the osteotomy itself and combined them with a demineralized bovine bone matrix, and then shoved it into the socket to ensure that we get a good, adequate bone fill. So here the BioOS or any DBBM will act as a space maintainer, interspersed with the autogenous bone, which will convert into the host's own bone. So essentially, you have the best of both the worlds. 3 months down the line, you see again a positive soft tissue architecture on the right hand side, and that's how we finish the case. So an intra-alveolar defect barrier is not required usually, provided the buccal plate is intact. The moment the buccal plate is not intact, it comes into a dehiscence type of a defect, which I'll get into in the subsequent slides, and I'll show you how to treat them. So the biomaterial here can be autogenous, either allograft and or DBBM. So if you want a good space maintaining property, allograft will not give you that. You will have to use some synthetic bone grafts or a xenograft. Autogenous to a certain extent will give you that, but it's not that long term. Meaning, it's not going to be space maintaining for a long period of time. It will eventually turn over. It might resorb under load. So you want something that maintains the space for a long period of time, which I feel synthetic bone grafts or your DBBM will be able to give you. We come to another type of a defect, which is called as a pseudo dehiscence type of a defect, where again the amount of bone that is available to us on the CT scan is less for the implant from the standpoint of having bone on the facial aspect. There's definitely a guarantee that the implant will be placed in native bone. But of course, you need that additional 2 millimeters to ensure long-term stability of the bone around the implants. So that's why we call it as a pseudo dehiscence type of a defect. We usually like to treat these kind of cases with a ridge expansion protocol using Densa burrs. So what that entails basically is that in the crest of the ridge, you make a small cut with a piezotome or a piezo surgical unit or any other similar device that you have, and you use the Densa burrs to expand the ridge. So that expansion can sometimes be even up to a millimeter or even 2 millimeters, depending on the ratio of the cancellous to the cortical part of the bone. So in this particular case, we were able to place 4 millimeter implants on the ridge, and we didn't have any dehiscence to begin with. So this was again just a contour type of a graft, but then again we felt that the graft would just not be stable like that. I thought that will keep flopping about. That's the reason why I chose to cover up the graft with a membrane. 4 months down the line, after a free gingival graft procedure, we had this outcome. Again, a positive soft tissue architecture, good 3-4 millimeters band of attached keratinized tissue. And that's how we finished the case. So the protocol here would be to ensure that you get your implant in a good prosthetically driven position. You ensure that there's a minimal amount of dehiscence. Now, to do that, you'll definitely have to have an auxiliary procedure like a ridge expansion. The barrier, of course, like I told you, it still depends. An autogenous, a combination of an autogenous with a DBBM or an allograft with a DBBM will be my biomaterial of choice. The third thing that we come to is dehiscence, which is the first type of dehiscence, or a class 1 type of a dehiscence, where only a couple of threads of the implants are exposed. This is a case where the patient had a congenitally missing lateral, and she needed a replacement for the same. When we looked at the CT scan, she had around 3 millimeters of bone. Being a lateral incisor, I thought that it's enough for me to place a 3 millimeter diameter implant. So we went ahead and placed a 3 millimeter diameter implant, and you can see a couple of threads are exposed here. So we went ahead and harvested some bone from the anterior nasal spines, and it was just in the vicinity. The first layer here was the autogenous bone, and the second layer here was a combination of the autogenous bone and the DBBM. In this case, it was Mineros XP, which is a carbonate apatite graft, xenograft. After that, we ended up doing a connective tissue graft to ensure that we had a good amount of soft tissue thickness here, and that's how we finished the case. So the technique here would be a sandwich technique, where the first layer that you put would be autogenous bone on top of the exposed implant surface, because you want good vital bone in contact with the implant surface. Barrier is mandatory here, because this is an out and out bone regenerative technique. So you want to exclude all those competing cells, or those non osteoblastic cells. So barrier here definitely is mandatory. The biomaterials of my of choice for me would be an autogenous and the BBM. Anything else will not work, because it just doesn't have all the three properties that you would look for in a bone graft, such as osteogenicity, osteoinductivity, and osteoconductivity. So none of the bone grafts in the market today will give you that. Only autogenous will give you all these three materials. So you have to use autogenous bone on the implant surface, and you can then subsequently layer it with a space maintaining bone graft of your choice. The other is a class 2 type of a dehiscence defect, where the amount of threads that are exposed are a little bit more. Now here nothing changes. You still have the same protocol, except that the barrier membrane now has to be form stable, right? Because the kind of defect that we have is going to be huge. You want something that offers a good stability to the bone graft. So we use the same protocol, where we made a small cut in the bone to ensure that we had a good amount of, or at least the implant was as much in native bone as possible. But that still wasn't the case. We still had close to 3 millimeters or 4 millimeters of implant exposure here. So we did the same thing. We went ahead and harvested some bone from the ramus, since it was just in the vicinity. We used a titanium mesh to cover up that entire bone graft. The first layer was the autogenous graft, and the second layer was slow resorbing bone graft, such as a xenograft. And eventually covered that up with a native collagen membrane. And what you see on the right side is the final image just before loading at 6 months. Now here, my choice of the barrier membrane would be the only change as compared to the class 1 type of defect, where we are dealing with a kind of defect which is much more larger, and you want the bone graft stability not to be compromised with a normal collagen membrane. So again, a sandwich technique. Any form stable membrane, a titanium reinforced membrane, or a titanium mesh will suffice here. And biomaterials of choice will be autogenous and xenograft of your choice. Now we come to a horizontal defect. By definition, these will have to be staged, because you just don't have enough bone to engage the implant and get enough primary stability. So the case that we had at hand was like this. We only had 2 millimeters of bone, along with a constricted mesodistal space. So we thought that this is a good candidate for GBR and a staged GBR. This was directly a combination of autogenous and demineralized bovine bone mineral, which is BioOss. And we covered that up with a BioGuide membrane. We ensured that it is tacked up and secured in place with these pins. So it's completely immobile. We added another layer of a connective tissue graft to boost the biotype at this stage, so that at the second stage we had a good amount of soft tissue thickness. And that's how we close. Now at 6 months post-op, you can see that there is a good amount of positive soft tissue architecture here, which is going to be visible to you all. We use a kind of a stent, a rudimentary stent, to ensure that we get the implant in the right buccolingual and the mesodistal position. And as you can see, we have more than 2 millimeters of bone around the implant, which is regenerated. So here, if it's a horizontal defect, definitely a barrier is mandatory. Now again, the severity of the horizontal defect will define what you use here. In this case, I had close to good 3 walls around the defect. So I was able to get by using a resorbable membrane. But if the walls are not that well defined, you would be better off by using a non-resorbable membrane. The ratio of autogenous and the xenograft should ideally be more than 50-50. The least that you can go is 50% autogenous and 50% xenograft. Ideally, I would like it to be anywhere between 70 to 30. You want a good amount of autogenous bone, plainly because you want the bone to turn over. You don't want it to just stay there, acting like a space maintainer for years and years, right? Now we come to vertical defect. Again, like I said, these kind of cases are not meant to be done simultaneously. Any mishap here is really a disaster. It's the worst possible outcome. It's going to be worse than what you began with, because you will have an infection, and you'll have bacteria on the implants, and just end up removing the bone. So it's always better to ensure that you deal with these kind of complex cases in a staged manner. So huge defects here, plus the proximity of the sinus. But we decided to deal with the sinus in a separate surgery. In this surgery, what we decided to do was just augment the vertical height here. In this case, the membrane of choice here was a titanium reinforced PTFE membrane. And we harvested some bone from the ramus, mixed it with around 30% of xenograft. 70% here was autogenous bone. This was tacked into place using some tacks which are locally available. And you can see the X-ray on the right lower side of post-augmentation. Now, the day this was 6 months after we finished the augmentation, but we thought that it's better to wait a little bit more and ensure graft maturation. So the re-entry procedure that you see on the right-hand side was done at 9 months. And close to 9 millimeters of bone that was regenerated horizontally and vertically. So we were able to place 4.5 millimeter diameter implants here. And this is the PTFE membrane that we removed. And this is the CT scan 1 year post loading. As you can see, stable bone. We also ended up doing an indirect sinus lift at the second stage surgery, which here was the implant placement. So good amount of bone all around the implant. Now here, a barrier is definitely mandatory, and a non-resorbable is definitely mandatory. I would go one step further and ask everyone to, in case if they're performing a vertical ridge augmentation, always cover your barrier or your non-resorbable barriers with a resorbable membrane, especially a native collagen membrane. It just helps cover up all these other small bone granules that you might have that are coming out of the non-resorbable membranes. The biomaterials here will again be autogenous and DVBM, and like we spoke for the horizontal defect, there again, the higher the ratio of the autogenous, the better it's going to be for your outcome. In fact, the faster you can re-enter. So moving on to the mishaps, there are two mishaps that I look at. The first type of mishaps are the intraoperative, which can either be minor. It can make the surgical procedure complicated. That's about it. It will not have any impact on the outcome of the process. For example, say bleeding. On the other hand, a major mishap can have implications on the graft healing. As far as post-operative mishaps are concerned, again, minor will have minimal effects. Major will have a considerable effect on regeneration, possibly leading to a complete failure of the graft. Right. So the first thing that we want to learn, or the first thing that we want to know, is surgical mishaps is flap damage. Surgical mishaps will also include vascular complications and neurologic complications as we go ahead. Now, one thing that we need to do to avoid any kind of flap damage is a very delicate handling of all your tissues. So now all of this starts at the first appointment when you're counseling a patient for GBR, right? So at least 1 week before the surgery is scheduled, you ensure that the gingiva is absolutely free of inflammation. He has a good plaque control. He has a good hygiene, because that in turn will ensure that you'll be able to handle the tissues nicely. The moment any gingiva is inflamed, it becomes more friable and it's more prone to tearing, or it's more prone to having dehiscences later on. So it's always better to do a good scaling root planing before you start with these kind of processes. I want you to use good surgical instruments that allow for gentle handling of the tissues. Good quality instruments. You need to incise flaps with 15C blades. Always ensure that you're in full thickness flaps only. You can also irrigate the flap constantly with saline to ensure that it's cooled at all times. So one thing that I have found to really help me in elevating a flap atraumatically is having these thin tissue pliers and these very small micro periosteal elevators. So essentially what you need to do is have a knife and a fork motion where you're using the pliers in the left hand and elevating the flap with the right hand with your periosteal elevators. If your incision is absolutely clear, you've revised your incision with a bow 2-3 or an Orban knife, it should just peel off. Any flap that does not peel off at the first shove is not a flap which is going to be clean, or has not been incised properly. So always remember, your first incision has to be clean, it has to be sharp, and has to be in the center of the keratinized mucosa. That is a secret to having a good clean flap, and that is a secret to avoiding flap damage. The other thing is, if you want to avoid flap damage, is to ensure the blood supply. Obviously, you want wide bases of the flap. You don't want to use flaps which are going to be thin at the base and thick at thin at the base and thick at the coronal end. So always use those kind of flaps. I want you to employ flap designs based on the defect, based on the evidence, and not use it just because you feel that you want to do this flap today. So a classic example is, say, if you want to use a papilla sparing incision, when would you do that? You would do that when the adjacent teeth are periodontally compromised, right? So that is one indication here. Even though I would not use a papilla sparing incision here, I would not cut across the frenum, because the frenum, being a muscle, is a rich source of blood supply. So especially in this case, I would still go for a classic trapezoidal flap with a releasing incision on one of the canines, and if required, I can always have another releasing incision on the opposite side of the canine. If you're dealing with the posterior mandible, this is the incision that I would follow. One releasing incision on the distal end near the retromolar pad. If it's a small defect, then I would just go maybe one tooth ahead and give a releasing at the mesial line angle of the tooth. If it's a bigger defect, I would go again one tooth ahead and give the same releasing incision at the mesial line angle. So like I said, 15C blades, Orban knives to revise the incision, ensure that you're on bone and you don't have any tissue tags, the periosteum is cut cleanly, and then go ahead and raise your flap. If you're planning to release the periosteum, which definitely you will be in any guided bone regeneration case, it has to be apical to the vestibular depth with one stroke of a new blade. You don't need to keep cutting it again and again. I'll go into the detail of how you need to release the periosteum in a minimally invasive way. So that will be one of the game changers as far as a tension-free flap is concerned. So we'll come to a perforation of the flap. Say if you've buttonholed a flap, now what would you do? If it's a 1 to 3 millimeter buttonhole, you can just close it in two layers with either a 5-0 or a 6-0 monofilamentous suture. If you feel that the flap or the buttonholing of the flap is more than 3 millimeters, it's always better to close with a connective tissue graft on the periosteal side, and then eventually suture it with 5-0 or a 6-0 monofilament suture. Now, neurologic and vascular mishaps, the only thing here that I can say is you need to avoid handling nerves. That's it. I mean, it's very hard to actually cause neurologic or vascular damage to a patient if you've been very thorough, if you've concepts are quite right, it's almost impossible for you to have neurologic or any vascular complications. I mean, of course, retractors touching on the nerves, or retractors compressing the nerve, all those are just transient nerve injuries which will be first grade at the most, and eventually recover to what they used to be the normal function in maybe a week or so. So of course, things like these you don't want to do in a surgery, right? You don't want to handle the nerve with a periosteal elevator like that. You can see it, you leave it alone. Ensure that if you're doing a GBR, all these small particles don't go around the mental nerve, irrigate it, because those eventually will act as irritants to the mental nerve. And I've really seen patients who can come back with some form of paresthesia, because these graft particles were irritating. If I look back, retrospectively, I've seen, why the patient was having these kind of issues. And I've seen my photographs, and I did see a couple of xenograph particles that were there that should ideally have been taken out. So that's one thing that we should keep in mind. You need to have a look at the CBCT properly. Don't rely only on what the radiologist sends you. Have a look at the CBCT or the DICOM data yourself. Map the nerve, map the mandibular incisor nerve. Like in this case, where it is. It's going to play a big role in where you place your implants or how you harvest your bone from the symphysis. If you're harvesting bone from the symphysis, I always like to follow a rule of 5, which basically means that all the borders of your bone graft or the block that you're harvesting should be at least 5 millimeters away from the adjacent mental foramens on the left and the right. It should be 5 millimeters away from the apices of the teeth, and it should be 5 millimeters away from the inferior border of the mandible. So that's a rule of 5 that one should adhere to in order to avoid any kind of damage to the teeth, any kind of pathologic fractures, or any kind of neurologic complications. If at all you feel that there is a nerve injury, if at all you feel that there is some form of transient nerve injury that you're anticipating, always consider some short-term steroids along with B complex. Vascular complications are not actually a problem. Mild bleeders are going to be a hassle for you intraoperatively, in the sense so the surgery will become difficult for you to execute flawlessly. You'll just have one more thing to manage. Although if you have major bleeders, that's always because of not knowing what vessels are. So if you know the anatomy, it's definitely going to preclude a lot of these severe hemorrhages. This is what we see with all the anterior severe bone defects with the sublingual artery and the sublingual vein. So if you follow all the techniques correctly, vascular complications aren't that many to document. So like I said, these small bleeders here, they'll just make surgery difficult for you. It's not going to be a problem from you're not going to have any major problems here. But on the other hand, things like these, such as the middle superior alveolar nerve in the sinus, if you end up cutting this, you'll have a bleeder. It'll spurt blood all over. It's just going to make things difficult. Anyways, it's a sinus. It's a high pressure situation. So these kind of things are always avoidable when you know that it's there. You can see it on the CT scan. You can take measures to make sure that you don't nick it. So classic example is this: you dissect bluntly around these branches of the sublingual artery and ensure that you don't end up nicking them and making a disaster of the case. So we come to exposures now. Exposures in resorbable membranes and exposures in non-resorbable membranes can be of two types. We'll first start with exposure of the resorbable membranes. Now, usually the resorbable membranes are the most friendly membranes as far as exposure is concerned. You'll definitely have, if you look at the literature, you barely have more than maybe 6 or 7% of exposures in resorbable membranes. On the other hand, non-resorbable membranes definitely brings that percentage up to maybe 20 or 25%. So it all deals with the membrane being a biomaterial and the way it is made. So the first thing is what kind of exposure you're dealing with, whether there is infection or there is no infection. If at all there is no infection, things definitely are simpler. You just need to call the patient every 15 days, every week to begin with, and then every 15 days monitor, ensure that the patient is on chlorhexidine rinses. The type of membrane that you're using will also depend as to what kind of inflammatory response the exposure will generate. So if you're using a native collagen membrane, if you're using a cross-linked membrane, if you're using something like an Osseous plus membrane, they all will dictate the kind of response that you get from the membrane on exposure. With infection, if there is any exposure and you have infection, the best thing to do is use some hydrogen peroxide and gently scrub the area using chlorhexidine. Also, start the patient on some broad spectrum antibiotics. Once the acute stage of the infection is over, you then go ahead and remove the membrane or graft, or at least remove a portion of the graft and the membrane which you feel is infected. You'll know that it's granulomatous tissue, and the moment you start curating into good bone, or you feel that the particles of the bone graft that you've placed are well adhered to the native bone, is when you actually stop. There's no way for one to know which graft is infected or which graft is not infected. It's all going to be on your judgment at that time. So what makes sense for us is what we've learned in oral surgery is to ensure that you curate the bone till you feel the bone, right? So that's the same thing that one should follow. Meaning, if there's, say for example, if I have a granuloma, I keep curating till I feel that I have good sound bone all around the apex of the tooth. So that's what I do even here, where if I feel that there's a small amount of infection, I'll start curating till all the granulomatous tissue has come out, all the whitish tissue has come out, all the pinkish tissue has come out. And once I see a good amount of bleeding, and once I see that the bone graft particles are adhering to the native bone, is when I stop. So a classic example is this of an exposure. You can see on the left picture where this was the situation pre-operatively. We went ahead and placed 3 implants and did some bone augmentation. After 15 days, we had a exposure here of the native collagen membrane. But luckily, the collagen membrane that we used was of native in origin, so it didn't, it was very tissue friendly. We ended up getting a little more amount of keratinized mucosa of in the area that was exposed. So that is the ideal situation that you want to be in. Another case where we use something like an Osseous Volumax, where again this membrane was left intentionally exposed. This was again to gain some keratinized mucosa. Osseous Volumax is been known to they claim that even if you leave it exposed, it does not cause any problems. In fact, it ossifies over a period of time, which I have found to be true. So it is definitely a case here where it did epithelialize, it did convert, it did ossify eventually, but still wasn't happy with the amount of the keratinized mucosa that we have, or the quality of the keratinized mucosa that we had here. So these small things, they do make a difference. Maybe in this case, we are just plain lucky where the graft doesn't get infected. I've had cases where we've left the membrane slightly exposed, and the xenogenic bone underneath has gotten exposed, or you still always have these small granules that keep exfoliating out of the tissue. So it's always better to have a tight mucosal seal over the membrane and the graft, no matter what these companies say or these companies claim. So this is that same case where we use the Osseous Volumax, and it's ossified, and we have almost 2 millimeters of bone all around the implant. Now this brings us to exposure in the non-resorbable membranes. The non-resorbable membranes make things difficult for us. If there is no exposure, if there is no infection and an exposure, what you need to do is have the same protocol as what we did for the non-resorbable membranes, which is scrub the area with chlorhexidine and hydrogen peroxide. You can also think about removing a part of the membrane and using a free connective tissue graft to just cover up that area. But it's safe to say that the moment any membrane is exposed, whether it's a resorbable membrane or it's a non-resorbable membrane, you will be looking at a compromised outcome, right? So the key here is to wait till 6 weeks, whether it's an infective exposure or non-infective exposure. The key here is to wait for 6 weeks, because at 6 weeks, you'd at least have some rudimentary form of an osteoid which will be formed there. So you'll not be ending up with a completely baseline scenario all over again. You'll definitely have something better. So all you need to do is to maintain the membrane exposure at a non-infective level and ensure that that doesn't go to an infective level. So that's what you want to aim at, and that's what you will probably achieve if you use hydrogen peroxide chlorhexidine regularly. See the patient for follow-ups. Then at 6 weeks, you can re-enter, remove the membrane, do the same protocol. If you feel that there are any graft particles which are infected, go ahead, curate them, use some broad spectrum antibiotics locally, irrigate that area nicely, remove any necrotic pieces of bone, advance the flap, use a connective tissue if need be, right? On the other hand, the infective exposure is the worst possible thing that can happen. You will have to start the patient immediately on antibiotics. Start with try and bring it to a state where the acute phase is completely passed off, and then go ahead and remove everything, all the graft, all the membrane. I'm not too sure whether this stage is going to be at 6 weeks or not. Usually I have had infective exposures, almost all the infective exposures that I have been predominantly in the first month. So they've all eventually gone back to what we had started off with. So that's one of the biggest disadvantages with using these non-resorbable membranes. So, how do you grade an infection? It can either be low grade or it can be high grade. High grade is the acute phase. You need to ensure that if the patient comes to you with a high grade infection, everything has to go immediately. Immediately, you need to remove the device, the graft, everything. If the patient comes to you with, a low grade infection where there's no pus, no fistula, a small amount of swelling, you can just re-enter, curate only the loose graft particles, cover it up with a native collagen membrane, and that's the end of it. Now, a classic example of a high-grade infection is something like this. You can see a popcorn sign. Everything is just red, inflamed. It just doesn't look right. You can see DBBM particles being exfoliated out. I like to follow this article, which is actually meant for how to treat infections in the sinus, but I found this technique to be equally effective in some of my ridge augmentation cases also. So essentially what this tells us is that if you have a situation like this where the patient is coming up with a high grade infection, you need to re-enter. You need to ensure that all the graft that is infected is completely curated out. The article likes to use, or the author likes to use doxycycline, which is a broad spectrum antibiotic, around 100 to 200 milligrams, which is diluted in zero point 0.1 to 0.2 ml of saline. And then you essentially make a putty out of the doxycycline and the saline, and you keep it in place for 1 to 2 minutes, curate everything out. The best part about doxycycline is it being a broad spectrum antibiotic and having these anti-inflammatory properties. It works wonders in these kind of cases, but you will have to take out everything there. Even if a small amount of graft particle is left behind, there is a chance that it could get reinfected, and you might have to do this process all over again. So that's the doxycycline putty. You keep it in place for a minute, and you close it again. And this is all that we removed. You can see that it's all granulomatous tissue. It's all infected and just not how we wanted it to go. Now, how will you circumvent mishaps is, first of all, when you're handling the membrane, you use a new set of sterile gloves. Always use templates. You want to minimize handling the membrane at all. Very, very important is to trim a non-resorbable membrane at least 2 millimeters away from the adjacent tooth. Native collagen membranes can touch the tooth surface, but it's always better to keep them away, because suppose if you've not done a thorough plaque or a scaling and a root planing, you don't want that tartar in contact with the biomaterial. Always ensure that the membrane is covering at least 2 to 3 millimeters over the margin of the bone defect. So something like this, where you can make a template out of the suture paper, and then shape the membrane directly. Always use screws and tacks. You ensure that the bone graft is stabilized. If it is not stabilized at the bone, if the membrane keeps flopping about, you might have it come under the flap, which will eventually lead to an exposure. So you can use these kind of screws, or you can use these kind of tacks, whatever suits your need. I always use a combination of both. These tacks sometimes, especially on when you're doing huge vertical augmentation cases on the lingual aspect, the moment you start to release it, it becomes very thin. So you have these kind of perforations of the lingual tacks. Also, it's always better to place these lingual tacks a little more apically. Now, tension-free closure, one more important point. How do you achieve that? You always release the periosteum apical to the mucogingival junction. You need to maintain a thickness of the flap, and you use a bilayered closure with PTFE sutures. Now, how will you do that? Especially in the posterior mandible, you have the mylohyoid muscle. Now, the mylohyoid muscle has basically two fibers, the superficial fibers and the deep fibers. So the zone 1 and the zone 2 deal with releasing the superficial fibers. The zone 3 deals with releasing the superficial fibers, but which are far more apically placed, right? So the double layer closure needs to be done in this manner, where vertical mattress sutures are first taken 5 millimeters away from the incision, or 5 millimeters apical to the incision, and over and above that you have interrupted sutures to secure the bone graft and to seal off whatever remaining gaps are there. When you're having these huge advancements, always ensure that the buccal flap or the buccal periosteum, or the periosteum of the flap which has been incised, is not tearing through the connective tissue. All your incisions should be very, very superficial, only in the periosteum. And then once these cuts have been made, you can go on and bluntly release the small superficial periosteal fibers here. So that way you'll end up not damaging the mental nerve. As far as the lingual flap is concerned, this is what I was talking about, where you release the superficial fibers of the mylohyoid muscle with a brushing motion using any of your periosteal elevators, the blunt ends, say a Pritchard. You can easily get 10 to 15 millimeters of release with the lingual flap, and maybe 5 to 10 millimeters with your buccal flap. So this is a small video where you can see how we are releasing the lingual flap, or releasing the superficial fibers of the mylohyoid muscle. Just a gentle brushing motion. So the superficial fibers are not attached to the periosteum here. They're attached to the deep layer of your mylohyoid muscle. Now, big mistakes here happen where we tend to give provisionals onto the area which has just been grafted. I prefer to follow this protocol, which is no provisional for 4 to 5 days. You have a fixed or a bonded bridge immediately. Yeah, you can do that, but ensure that there's no pressure on the wound. You need to relieve pontics to release all the pressure, and distal extension cases should not be provisionalized. Definitely no to dentures at all. So usually when I do any anterior ridge augmentation case, and luckily in this case there was a bridge, we ensured that we trimmed off all the pontics and had a hygienic pontic design here. So to conclude, it's definitely technique sensitive. I wouldn't want all of you all to get disheartened or be disenchanted by whatever I've told you. I don't want you shying away from doing GBR. It's definitely technique sensitive. It's achievable. The key I keep telling again and again is case selection, ensuring you follow everything to the book, because eventually it's like a puzzle. All the pieces need to fit in perfectly in order for it to work. So I hope that the presentation has helped you. And I would recommend everyone to who's beginners or experienced surgeons here, to go through these two books and articles, which I feel have really helped me on my journey of guided bone regeneration. Of course, this is the 30-year book. I've not read the 30-year book. I've read the 20-year book, but it still helped me in getting a better understanding of what techniques to choose. Last but not the least, I'd like to thank all my mentors, everyone on this slide here. I wouldn't be where I am without them. So I'd like to take this opportunity to thank all of them. And if there's any other questions, Rajiv sir. Sir, I
Sorry,
can't hear you.
I was mute. I was mute. It was a fantastic lecture. You covered everything. It's such a wide and vast topic. You covered everything, including the complications, how to handle complications. You showed so many lines of high quality evidence as well. And I really liked the way you simplified the whole concept, the complex things.
Thank
And
you.
now I would like to ask some of the questions that our viewers have sent.
Yes.
The first question is it possible to achieve zero bone loss?
So zero bone loss with grafts or zero bone loss with implants? I mean,
I think somebody has just read Thomas Linkovich's name and correlated the book, and he has
so
asked the question.
there are multiple factors definitely for zero bone loss as far as implants are concerned. I'll assume that it's zero bone loss with implants. There are multiple factors, right from your implant design factors to your prosthetic materials. It's definitely possible. What he recommends in the book is that you use implants which are preferably platform switched, because or if you're not using platform switched implants, you ensure that you get the position of the implants in the apicocoronal dimension to be absolutely right. If it's a matched platform, you need to ensure that it's 0.5 mm supracrestally. If it's platform switch, then depending on the type of platform switch, on the type of connection that it has, it's supposed to be how deep. Depending on prosthetic factors, he talks a lot about cleaning the abutment, using zirconia as a custom abutment solution, which is much more kinder to the tissues than titanium or lithium disilicates, or even, of course, by all means, chrome cobalt. He talks about using zirconium. He talks about using lithium disilicate as a veneering material because it's kinder to the occlusion. So yeah, definitely it is possible, but I mean, I myself, if I'm in all honesty, if I'm candid with everyone here, there's definitely areas or sometimes where it doesn't work. So it's all about the journey where we try to find out why this has happened. But based on what Professor Linkovic says, yes, it is definitely possible if you follow his protocols. But in our situation, a lot of things come into the picture, especially cost, because any custom zirconia abutment is not going to be very cheap, and not every patient is going to go in for those kind of solutions, no matter what. They don't understand what zero bone loss concepts is. So we have to try and figure out a way as to how we can manage that, or in whatever little way. If you want to avoid cement remnants, you ensure that you have a screw retained restorations, go for milled prosthesis. So that by itself is a completely different topic altogether. I'll be happy to share some articles from Professor Linkovic's on the page, so the participants can access it and get some more clarity on this.
Great, great. And how common is that you end up measuring the vertical thickness of the soft tissue, and if it is less, you have done soft tissue grafting over the ridge?
Honestly, sir, I've only done it once till now,
Okay,
because most, I mean, all of these times, at least the implant systems that I was using were having most connections and were allowing me to place implants subcrestally, so I didn't feel the need to augment the
so instead of
tissue.
going for soft tissue grafting, you would rather get the
Exactly.
positioning right picocoronally.
Yeah, and predominantly most of the cases I have dealt with have a good amount of height. The canal is far away. I can easily place a 10, 50, 12 millimeter implant. So rarely. I mean, I had got one mucoderm from there, and just because I had to use it, I used it. So it was, it is not something that really warranted it.
Okay, okay. Next question is, where do you use deep freeze-dried bone allograft and xenograft? I think you have covered it already, but
Yeah.
because some viewer has asked it specifically.
So any none of the bone substitutes will ever give you all the three properties, but at least what these xenografts can do is they will help you maintain the space. So where would I ideally use xenografts is if it's there in extraction sockets, if the jumping distance is more than 2 millimeters. If I want, say, bone regeneration, if I want a good amount of vital bone formation, is where I would use allograft. Not always have I used xenografts in isolation in sockets, or not. I've never used off late xenografts in isolation. I've always combined them with autogenous and allografts to ensure that there is a good amount of at least some vital bone in there. So essentially, to answer your question, only xenografts will be used only for contour grafting, nothing else, in my opinion. Otherwise, they all
Right.
should be combined with some form of osteogenic
Bone
potential.
formation. Yeah. Okay. Bovine xenograft versus porcine carbonate appetite xenograft, in your experience, and which one has better long-term outcome?
So I honestly, sir, have I mean, this is what I've read, that carbonate appetite is supposed to be better from the standpoint of the porosity. It's supposed to be more porous, and the calcium and phosphate ratio is much more favorable as compared to the bovine, the bios. So there was one uh, a substitute called Bone XP. I think Mineros XP is a carbonate appetite bone graft. So definitely, in terms of converting or having a higher osteoconductive potential, a porcine carbonate appetite is much better than say a traditional xenograft like Bios or a
Okay.
DBBM.
And what is your experience with economical grafts, which most of the implantologists in India would like to have? Beta tricalcium phosphate, beta
Yeah,
TCP has.
it's definitely a good solution. But I would always, sorry, I think, sir, you're cutting in and out.
Is it good?
Yeah, now it's good.
Yeah.
Yeah. So as far as beta tricalcium phosphate is concerned, I would always like to combine it with hydroxyapatite, so you get the best of both the worlds. You will have tricalcium phosphate that converts faster, and you will have hydroxyapatite that maintains the space. So always have some form of a higher ratio of tricalcium phosphate over hydroxyapatite. I'm definitely the proponent of those two materials.
So you will have more beta TCP for faster turnover.
Yes.
Okay. Okay.
Yes.
A few more questions. Um, how long is the waiting time after GBR for implant placement?
It's multifactorial, the type of defect that you're dealing with. So assume that if I'm just dealing with a staged horizontal bone regeneration surgery where the walls are fairly converging, it's a favorable defect. I would ideally wait at least 6 months.
Okay.
If it's a particulated graft, if it's a bone glob, then I would probably wait for 4 months.
Okay. For people who are not well versed with autogenous grafts, especially block grafts, what do you advise? Autogenous chip makers or bone scrapers for bone harvesting?
Yeah, so you can definitely use all of these things. It's always a hassle trying to find the right equipment from the standpoint of cheap and effective. You'll never get best of both the worlds. So auto chip maker, I don't think anyone has it now. I may be wrong, but bone scrapers also, you get good ones by Meta, which are reusable, and it does work out to be a little more economical as compared to the safe scraper. Trefines and auto chip makers are also honestly a tool that I feel that one should have, apart from the safe scrapers and the Meta bio scraper.
Okay. Last question. What is your experience with PRF and sticky bone?
I haven't used any of these. Maybe when I was in college, I used to use it, but after that, I haven't used. I don't find any. I mean, I definitely find some merit in it, but it's not something that will drastically improve the outcome of the surgery. I rather. I mean, this is of course my opinion. With all due respect to everyone who's been using PRFs and sticky bone, it's good to have sticky bone if you're to have the bone graft in one place and you don't want it moving about. But as far as PRF is concerned, the only advantage that it has is just better soft tissue healing. in my experience. I've never had a PRF actually being a factor that plays a big role in how my bone graft has healed or how well the defect has been regenerated. There are a lot of other factors that go into making that happen. PRF, I don't think, is one of them.
Okay. So I think we have come to the end of all the questions sent by the viewers. Thank you, Madhur. Thank you so much. It was a fantastic session.
Thank you so
And
much, sir.
I'm sure all the implantologists and budding implantologists who watch this lecture have taken a lot of take home points with this. And thank you once again. And
I'm
I
glad.
wish you all the best in your journey and the kind of amazing cases you are doing. And
Thank you so much.
to all the viewers, thank you for joining us for this session. We'll be coming soon with our next episode number 14, with the same philosophy. Each episode, one clinical challenge. Thank you
Thank you
so
so
much
much.
and
Thank you
good
so
night.
much.
Thank you,
Thank you.
Mother. Thank you so much.
Thank you. Good night.
Good night.